Hyperbaric Oxygen Therapy by Dr. Frans Cronje. The objective of this presentation is to provide an overview of hyperbaric oxygen therapy as provided at King Hamad American Mission Hospital. The topic itself is quite extensive, so this presentation only provides essential basics, because there are details that would apply to individual specialities that baromedicine supports. Nevertheless, it's valuable because it offers a framework for thought of the clinical processes involved in referring patients for hyperbaric oxygen therapy. King Hamad American Mission Hospital offers a variety of tertiary specialty services, many of whom may benefit from the support that HPO therapy can provide. By simply looking at the specialties represented, one quickly sees the areas of synergy. The predominant ones are indicated with red arrows here: nephrology and urology, wound care, adult emergency department, neurology, diabetes and endocrinology, as well as dermatology and plastic surgery. Please notice that all patients referred for baromedicine need to have appointments made for them at the main reception at King Hamad American Mission Hospital. Please call if you'd like to make an appointment for a patient there. We cannot register patients at our facility. Although we may not necessarily have the opportunity to invite you all over to our facility, the short video clip gives you an idea of what a patient might experience when being referred to us. Very importantly, patients should be advised that there are certain items that cannot be taken in the hyperbaric facility for reasons of fire safety, and also because they may damage the hyperbaric chamber. Advisory notices are posted all over the facility. And here are the three people involved with baromedicine and advanced wound care. From left to right, we have Sister Hiska Smart, who has extensive international experience in wound care and baromedicine. She has practiced at King Hamad University Hospital for several years. And then there's myself, and I've been trained internationally and involved with baromedicine and wound care for nearly 3 decades. And Sister Lucy Cronje, who was one of the first nurses trained in baromedicine in Southern Africa, and it also has extensive experience, so you can rest assured that your patients will be in good hands. Although hyperbaric oxygen therapy is safe and should be painless, for the purposes of fire safety, infection prevention and control, and privacy of patients, we keep the treatment area isolated from the rest of the facility. So with that introduction, I will now be focusing on hyperbaric oxygen therapy as an adjunct to surgery, diving, and emergency medicine. Less common and unconventional applications such as stroke and cerebral palsy will not be considered here. We would also like to offer you the opportunity to pose questions to settle any concerns you may have about the therapy, if not during a live presentation, then via comments or email. When it comes to hyperbaric oxygen therapy itself, to set the stage, healing is the preferred biological response to any injury. The process of healing is entirely dependent on perfusion and oxygenation. As such, Wound healing failure, more often than not, suggests that either or both of these are inadequate. Now, whilst perfusion and oxygenation are of course related, they are not synonymous. Good perfusion can sometimes compensate for mild hypoxia. Similarly, hyperoxygenation can sometimes compensate for mild ischemia, and this is where hyperbaric oxygen therapy fits in. Hyperbaric oxygen, or HPO, can be defined as the use of 100% oxygen breathed under pressure in excess of 1.4 times atmospheric pressure and delivered to the tissues of the body via the circulation to provide a therapeutic benefit. This is achieved by increasing the inspired PO2, which increases an alveolar PO2, and thereafter an elevated arterial PO2. The concentration of oxygen cannot exceed 100%, and airway pressure cannot exceed 15 to 20 centimeters of water for any significant duration of time. Therefore, the only practical way to increase the partial pressure of inspired oxygen is by placing the entire patient in a compressed environment, typically at a pressure that is 2 to 3 times atmospheric pressure. HPO can be provided in 2 styles of chambers: the so-called multiplace chambers that can accommodate 2 or more persons, but involve significant logistics and also determine that the patients receive the same treatment at the same time. These chambers are pressurized with air, and the patients breathe oxygen under pressure through a mask, head tent, or ET tube. On the other hand, monoplace chambers accommodate 1 person. Usually, the entire chamber is pressurized with oxygen, and the patient therefore has no need for a mask or a hood. Treatment pressures can also be individualized. Support functions are provided from outside the chamber with medical access ports, such as for IV infusions, monitoring, and even ventilation. Access into and out of the chamber is via a specialized gurney, and patients are given cotton scrubs to ensure fire safety in the pure oxygen environment. Many clinicians may feel somewhat uncomfortable about the prospect of not being able to have hands-on contact with patients during therapy. However, after doing this for many years, we've become familiar and much more comfortable and preemptive in planning for treatment in which the patient, although physically next to you, is actually at a pressure equivalent that puts them 10 to 20 meters away from you. Here we are preparing a patient with carbon monoxide poisoning for hyperbaric therapy. It is possible to ventilate a patient in a monoplace chamber with a fairly unsophisticated ventilator. It is only able to provide mandatory ventilation, and as such we would only recommend its use where hyperbaric oxygen therapy is the primary treatment, as may be the case in arterial gas embolism, decompression sickness, and carbon monoxide poisoning. When we think of oxygen and its effects on the body, we naturally consider the physiological effects first. Although possibly the most familiar, there is much more to oxygen than the generation of ATP. There are at least 5 groups of physiological effects in the body, which are all relevant to your patient. As mentioned, it plays an integral role in the formation of energy, but also the synthesis of various substances, including fibrous tissue and adrenaline. It assists with the detoxification of various chemicals in the liver, is vital to the body's ability to destroy bacteria and fungi, and it plays several complex roles via the production of a substance called nitric oxide, as well as other oxygen signaling molecules that affect, amongst other things, blood vessel caliber, and even memory. Once we administer in excess of 50% oxygen at 1 atmosphere, there's an increase in the number of pharmacological effects that start to occur. Dissolved oxygen starts to become a primary mechanism of oxygen delivery. Blood vessels narrow selectively with the benefit of reducing edema. New microblood vessels form over time, and many cellular effects are enhanced. There are also direct effects related to pressure and gas gradients, used to eliminate bubbles and excess nitrogen or inert gas. Here is a typical hyperbaric treatment table. It involves pressurization to 2 or 2.5 atmospheres of pressure, which is roughly the tire pressure of your car, after which the patient then breathes pure oxygen at that pressure for a period of 90 minutes. When pressures higher than 2 atmospheres are used, air brakes are added to avoid problems with oxygen toxicity. Oxygen is transported in the blood in 2 primary forms, bound to hemoglobin and dissolved in plasma. Note that oxygen bound to hemoglobin is only potentially available to the body. In the same way, passengers on a bus may or may not become customers in a shop. On the other hand, dissolved oxygen, which diffuses readily out of blood vessels, participates directly in metabolism, the business, as it were, of keeping the body functioning. When gas tension is high, the oxygen diffusion distance can be increased 3 to 4 times. Hemoglobin may be fully saturated with oxygen, but the increase in plasma-borne oxygen under hyperbaric conditions may even be sufficient to sustain life without hemoglobin, making oxygen delivery independent of red cell passage. As we increase the PO2 in the lung, the amount of oxygen bound to hemoglobin is not increased significantly. But in keeping with our analogy, the buses, in this case hemoglobin, only have a number of seats for oxygen. Once they are full, they are full. But on the other hand, one can increase the number of customers or pedestrians through the dissolved oxygen component. And under pressure, breathing 3 atmospheres of pure oxygen, the plasma-borne oxygen increases oxygen carrying capacity of blood by 25% in its free form. This translates to about 6 milliliters of oxygen per 100 moles of blood, or the average oxygen extraction from blood by tissues. Because, as you now realize, oxyhemoglobin measurement, that is HbO2%, is unhelpful in determining tissue oxygen delivery, the essential tool in the practice of baromedicine is the so-called transcutaneous oximeter. Speaking slightly simplistically, this may be thought of as doing a blood gas through intact skin. It's non-invasive and gives you a PO2 value. For the most part, TCOMs are used in 2 ways. Firstly, to determine whether hypoxia is present, and then to determine whether this may be reversed. We therefore start with a so-called reading, determining whether there is hypoxemia in a patient breathing air. We differentiate tissue levels in diabetics and non-diabetics. If the values are below 45 and 35 millimeters mercury respectively, hypoxemia is a barrier to healing. So if we suspect that there might be a central cause of hypoxemia, we can do comparisons or ratios between a normal site such as the second intercostal space and the wound. This indicates where the priority for reversal of hypoxemia may lie. Correction of central hypoxemia, revascularization, and alleviation of edema always take precedence over hyperbaric oxygen when these options are available. When they are not, however, we now need to confirm whether the hypoxemia can be reversed therapeutically. We can elicit a response, and we do this in two ways. If the patient has a low value, we give them normobaric oxygen, that is, oxygen by mask in a ward. If this already achieves a transcutaneous value of 100, it provides adequate proof of vascular reserve and oxygen inflow. But if the value remains persistently low, we need additional confirmation. So the gold standard is a transcutaneous value of 200 PtCO2 under hyperbaric conditions. This is the single most reliable predictor of healing that we know of. With some exceptions, failure to achieve 200 mm mercury under hyperbaric conditions is a contraindication to HBO and may become an indication of either revascularization or an amputation. When considering the effects of hyperbaric oxygen, it should be remembered that oxygen is not merely a substrate for the body's metabolism, particularly when HBO is employed within the pharmacological range, and those effects become evident, such as inducing DNA transcription and the expression of growth factor receptors. To make the key concepts of HBO more memorable, they can be divided into 5 groups: hyperoxygenation, vasoconstriction, neovascularization, altered cellular functions, and pressure and gas gradients. The following slides will illustrate clinical examples of where these effects are evident. In doing so, we'll achieve 2 goals. We'll demonstrate the primary mechanism and explain the rather diverse range of indications for the use of HBO. Firstly, hyperoxygenation. Here perhaps the most classic illustration can come from the cellular asphyxiation that occurs with carbon monoxide poisoning, as well as cyanide poisoning. Hyperbaric oxygen therapy is the natural antidote to these forms of poisoning. Both carbon monoxide and cyanide mimic the role of molecular oxygen. They interact with the natural binding sites, which in the case of carbon monoxide may range from hemoglobin, myoglobin, to cytochromes all the way down to cytochrome AA3, the last step in the electron transport chain in the mitochondria. Most of us are familiar with carboxyhemoglobin. Intriguingly, the catabolism of hemoglobin produces carbon monoxide, which is why even unexposed normal individuals have a carboxyhemoglobin level of 1 to 3%. Values of 10% typically indicate some form of pollution, of which smoking is the most common. When we exceed 11%, and especially 25% or more, carbon monoxide intoxication can safely be presumed. This slide shows the washout curves of carbon monoxide from hemoglobin. But let me restate that carboxyhemoglobin is more a marker of carbon monoxide intoxication. There are significant cellular toxicity effects that remain even once oxyhemoglobin levels have returned to normal. Nevertheless, the half-life of carboxyhemoglobin in air is approximately 5 hours, which means it takes more than a day to eliminate. Breathing 100% oxygen at 1 atmosphere reduces this to 6 hours, and in a hyperbaric chamber to 2.5 hours. But more important than the removal of carbon monoxide from hemoglobin is its removal from cytochromes and the long-term effects, such as delayed apoptosis of neurons and cardiac myocytes. Patients who show significant neurological and cardiological impairment after 4 hours of oxygen first aid and resuscitation may benefit significantly from additional hyperbaric oxygen, particularly with neurological or cardiac dysfunction and in the case of pregnancy. Hyperbaric oxygen achieves much more than just increasing blood oxygen content. Diffusion of oxygen into tissues is what ultimately determines cellular oxygenation. Under normal conditions, oxygen only diffuses some 100 microns away from a functional capillary. This can be increased by a factor of 4 on the arteriolar side of a capillary and twice the distance on the venular side. HBO therefore overcomes diffusion barriers such as edema and can compensate for destroyed or congested capillaries such as in burns and in crush injuries. HBO cannot prevent the primary tissue loss of an injury, nor can it reverse primary necrosis. However, after most acute injuries, there is a so-called injured tissue gradient, and secondary tissue loss which occurs as a result of edema, infection, and ischemia may be reversed. Non-viable tissues also undergo aseptic necrosis or mummification, which allows the surgeon the opportunity to make a delayed decision on what is salvageable and what is not. To obtain the greatest benefit, however, HBO should be commenced within 24 hours of an acute crush injury. The longer the wait, the less the amount of compromised tissue which can potentially be saved. This is one of my patients involved in a motor vehicle accident resulting in a mangled ear. The purpose of showing you this is so that you have a physical demonstration of the infusion of oxygen into tissue. The first image was obtained prior to commencing HBO. In showing this to surgeons, opinion ranged from hopeless to watchful waiting. The 10 and 20-minute interval between photographs taken through the transparent hull of the monoplace chamber tell a story of their own. Notice how oxygen diffusion into the area that previously appeared either non-viable, cyanotic, or even necrotic started to reverse. This individual made a complete recovery without a need for further reconstruction. HBO is also a potent systemic vasoconstrictor. The process is self-limiting, however, in that the effect is attributed to an interaction between nitric oxide and superoxide. In areas of adequate perfusion, superoxide reduces nitric oxide, with the net result of vasoconstriction. But in hypoxic tissues, nitric oxide levels are increased and vasodilation occurs. This therapeutic strategy is familiar to those of you involved, particularly in sports medicine. The application of ice reduces vasoconstriction, and hypoxemia is avoided by lowering the metabolism of cells as a result of the hypothermia. In the case of hyperbaric oxygen, however, the effect of vasoconstriction gives you the same benefit by reducing the hydrostatic pressure that causes further extravasation after the injury, but unlike ice, it maintains hyperoxygenation. So it's therefore able to achieve oxygenation of tissues and certainly able to reach deeper tissues than would be available through the topical application of ice, such as intracranial and open traumatic injuries. This unique anti-edema effect makes HBO the ultimate ice pack. Once again, the effect is most potent when delivered between 6 and 10 hours after the original injury, before the leakage of protein reduces the effectiveness of the resorption of edema. To illustrate this phenomenon, let me show you one of my patients with a burn injury. The patient had approximately 18% burns, including second and third degree tissue damage, which was the cause of a flash fire related to methylated spirits. There was no significant inhalation injury. Most plastic surgeons looked at the wound and predicted that the patient would spend at least 6 weeks in the hospital and would require debridement and grafting. And certainly those of you that are familiar with burn injuries will recognize that the amount of swelling 2 days after the burn is significantly less than would be anticipated otherwise. The patient could actually even open his eyes. The crusting you see is the result of the application of silver sulfadiazine or flamazine. At this stage, the patient had received 5 hyperbaric treatments. This is 4 days after the burn and 8 hyperbaric treatments. The further reduction of swelling is obvious. And here we are, day 9, and 10 hyperbaric treatments. The patient was ready for discharge. There was no scarring, nor any need for grafting, not even in those areas that were identified as third-degree burns. These recovered through autologous grafting of epithelium budding from deep intradermal sweat glands and hair follicles. These produced small islands of epithelium which ultimately covered the entire area. So this patient went from the image on the left to that on the right within 9 days due to the early application of HBO. Ongoing tissue loss was averted, swelling minimized, and infection avoided. And of course, partial thickness burns were salvaged. New vascularization, angiogenesis, or granulation tissue formation as it's often called, is synonymous with healing. The process depends on a number of cellular and biochemical events, however. The primary stimulus, though, appears to be the oxygen gradient between normal and abnormal tissue. In acute wounds, the distinction is obvious. In chronic wounds, however, especially in irradiated wounds, the transition between normal and abnormal tissue is blurred and no longer distinct. The lack of oxygen contrast lies at the heart of an irradiated wound. These are transcutaneous oximetry values, and as can be seen, the transition from normal to abnormal is gradual and therefore does not elicit a healing response. However, under hyperbaric conditions, the contrast is restored and angiogenesis is initiated. Eventually, the process self-terminates when the contrast is, again, insufficient to stimulate further angiogenesis. This is a valuable angiogenic dose-response curve attributed to HBO. It is a way to easily explain how hyperbaric oxygen has an initial latent phase, and then between 6 and 14 treatments there's a rapid rise, after which it plateaus between 20 to 24 treatments. The duration of this angiogenic response is long-lasting and has been monitored in excess of 10 years. Importantly, though, one only achieves approximately 80% of the normal vascular density, and this is why pre- and then post-operative HBO is so important. It is particularly encouraging that the results are durable, and therefore the healing and reconstructive efforts are also. This type of response is not unique. This is a diabetic patient referred to us by the orthopedic surgeon who wanted to do a below-the-knee amputation. After doing transcutaneous oximetry, we were able to determine that the wound was likely to heal. After 15 hyperbaric treatments, granulation tissue is now evident and went on to spontaneous closure of the wound with adequate wound care. Importantly, though, the durability of the angiogenic response is evident. If you look at the date, this is 16 months later, and this individual, who was a gardener and on his feet every day, was able to continue with his normal working career. Next, altered cellular effects. Many processes in the body are at submaximal rates with physiological PO2s, and HPO2 therefore has the ability to increase these certain cellular functions. In the wound healing cascade, all those processes labeled in white are oxygen dependent and may be accelerated or in many cases made possible with high PO2s. Chronic wounds, by definition, remain trapped in the inflammatory stage. An additional effect of oxygen, and particularly hyperbaric oxygen, is that it increases the bactericidal effect of neutrophils. This is proportional up to a PO2 of at least 1,000 millimeters mercury. This has been verified using some of the most notorious pathogens. Collagen cross-linking and tensile strength of surgical wounds is also attributed directly to partial pressures of oxygen. This may sometimes be achieved even with ward oxygen, but is definitely the case with hyperbaric oxygen. Many antibiotics are also more effective in the presence of high PO2s, without increasing either tolerance or toxicity. The transport of aminoglycosides over bacterial cell walls is an oxygen-dependent process, which is why they're ineffective in anaerobic infections, but not so under hyperbaric conditions. Membrane-active antibiotics like penicillins and vancomycin also are particularly synergistic with HPO. Clindamycin, sulfonamides, and rifampicin that interfere with the metabolism of bacteria also synergize very effectively with HPO. And then there's ischemia reperfusion. White cells in the presence of trauma become activated and release adhesion molecules that attach to damaged endothelium and paradoxically cause an aggravated injury. This mechanism is deactivated for a period of time and allows the tissue to be preserved and not to undergo the typical mottled ischemia reperfusion phenomenon. It does require that HPO be started within 6 to 8 hours. Now that we've discussed the various mechanisms of HPO, what medical conditions may benefit from it? So let's start putting this all together. Different hyperbaric societies in the world categorize and classify indications somewhat differently, but this is a very standard list of indications. If one merely looks at the indications without understanding the underlying mechanisms of action and pathophysiology, it may seem that HPO is used randomly. But now that hyperoxygenation, vasoconstriction, neovascularization, cell effects, and pressure and gas gradients are understood, it stands to reason why HPO would work for decompression illness and arterial gas embolism, carbon monoxide poisoning, gas gangrene and necrotizing soft tissue infections, acute ischemias such as crush injuries, compartment syndromes, and acute traumatic ischemias in general, acute thermal burns, compromised skin grafts and flaps, acute retinal artery occlusion, sudden sensorineural hearing loss, and acute blood loss anemia where transfusion isn't possible. It also explains its role in selected problem wounds, refractory osteomyelitis, radionecrosis of bone and soft tissue, and cerebral abscesses. Depending on whether it's emergency medicine or surgical disciplines that rely on the assistance of hyperbaric oxygen, there may be a predilection for certain indications. Nevertheless, the mechanisms are common, and whenever the use of HBO is to be considered, always match the underlying pathophysiological process with a mechanism of action. In the time that remains, I'd like to emphasize some of the indications where HBO may make a tremendous difference. In the case of crush injuries, we've already indicated that a significant amount of secondary tissue loss may be avoided if HBO is commenced early on. In extensive studies that have been done in this area, it has been defined that Gastillo grade 2 and 3 injuries, especially in individuals over the age of 40, benefit greatly from the use of HBO. In the case of diabetics who suffer the triad of neuropathy, ischemia, and infection, transcutaneous oximetry is able to identify those patients most likely to benefit from HBO therapy. Usually, using the Wagner classification, it is the class 3 and 4, which is the infective groups of diabetic foot infections that are referred for HBO, whereas the class 5 indicates total destruction of the foot, and transcutaneous oximetry may then assist in identifying the most distal functional amputation for the patient in question. The idea is, indeed, to provide the most distal amputation. By avoiding proximal amputations, morbidity and mortality are reduced, and it is more likely that the patient may be rehabilitated with a prosthesis. Finally, radiated tissue injury offers a unique challenge, particularly to reconstructive surgeons, and it is here where hyperbaric oxygen can play a significant role. In the 2 to 3 weeks prior to a course of radiotherapy, excision of a tumor does not require hyperbaric support. Similarly, 6 weeks following a course of radiotherapy, there is a window period in which healing is largely preserved, and it is usually here where reconstructive efforts are employed. 4 to 6 months after a course of radiotherapy, tissues become vulnerable, and surgery in these tissues usually produces an unsatisfactory outcome, with dehiscence and often an unhealing wound and progressive loss of tissue. It is here where HBO can play a significant role. The important thing is to recognize that HBO should be employed prior to surgery in these areas. You might recall the dose-response curve of angiogenesis in an irradiated wound. We would like at least 2 to 3 weeks of hyperbaric treatment to get the vascular density back to close to 80% of normal, and then as soon as possible after surgery has been performed to ensure that the deficit of 20% of vascular density does not lead to a complication in the post-surgical wound. there is sufficient evidence to strongly recommend and support the use of HBO prior to surgery in an irradiated area. If tissue breakdown is already present, 30 preparatory treatments are advised. In certain cases, fewer numbers of treatments may be appropriate. If necrosis is to be prevented, 20 preparatory treatments are recommended. The importance, though, is that hyperbaric oxygen should resume very shortly after the surgery is undertaken. The take-home message here is that surgery should not be undertaken in an irradiated field prior to providing hyperbaric oxygen therapy. The most common error in combining HBO and surgery in an irradiated field is neglecting the immediate post-operative support. Whilst angiogenesis is durable, it is only 80% of normal, and therefore immediate post-operative HBO is vital to secure a good outcome. Intriguingly, the delay may be several months or even years after the initial HBO has been provided, meaning that once the first 20 treatments have been provided, surgery can be delayed by months or even years, and only 10 follow-up hyperbaric treatments are necessary because the vascular density has been restored. What are the contraindications to HBO therapy? Well, for the most part, they involve drug-drug interactions, of which chemotherapy, and specifically doxorubicin or adriamycin and cisplatina, are the most important, during which HBO should not be provided. Bleomycin adds the additional complication that pulmonary fibrosis may follow the administration of oxygen even years after it's been administered. In practice, though, various studies have shown that this is not as much of a concern as was previously believed, and regular pulmonary function follow-up avoids those patients that may have an adverse outcome. Disulfiram and carbonic anhydrase inhibitors can increase the toxicity of oxygen and therefore should be avoided. Lastly, an untreated pneumothorax should not be put in a hyperbaric chamber. Once the pneumothorax has been treated, however, there is no longer a reason not to treat these patients if they have an appropriate indication for HBO therapy. What are the dangers and side effects of HBO therapy? The most common challenge with hyperbaric oxygen therapy is middle ear barotrauma. Because pressure balance between the external and middle ear is essential for integrity of the tympanic membrane, it is necessary for patients to be able to equalize or normalize the pressure in the middle ear to the ambient pressure. It is quite common for patients who have received head and neck radiotherapy or have chronic allergic conditions to struggle with this. Approximately 10% of patients who have received head and neck radiotherapy need grommet placement prior to HBO therapy. Patients with other histories of eustachian tube dysfunction may be able to be treated with a temporary myringotomy, especially if few treatments are necessary. In-ear problems are virtually unheard of unless the person forces the eustachian tube to equalize, increases intracranial pressure, and this results in an inner ear fistula. But this is a very rare complication. Barotrauma of the sinuses and teeth are fairly rare and can be managed with topical decongestants for the most part. Barotrauma of the lungs is a theoretical concern, but the only real concern is that if a seizure were to develop as a result of oxygen toxicity, pressure should not be decreased during the tonic stage of the seizure where breath holding occurs. Once the clonic stage is reached, the patient may be safely decompressed, and damage to the lung and brain are extremely uncommon. In very rare instances, massive bullae or acute bronchospasm may increase the chances of barotrauma, but in practice, this almost never occurs. Pulmonary oxygen toxicity is a very rare occurrence with hyperbaric oxygen. Only if more than 4 hyperbaric treatments are provided per day, which may be the case with acute blood loss anemia, or if a patient is receiving more than an FiO2 of 0.4 in an ICU or in the ward between treatments, is this likely to happen. So it is more a theoretical concern than an actual one. And lastly, as mentioned previously, 1 in 10,000 hyperbaric treatments may result in an oxygen toxicity seizure. Oxygen toxicity of the central nervous system is a condition that is never seen at 1 atmosphere, but may occur under pressure. It is rare and does not result in brain damage. However, it is something we wish to avoid, and therefore, if a patient reports abnormal visual, auditory, or other symptomatology, they are provided with air brakes to avoid this from happening. So where does HBO fit into the overall picture of medical healthcare? Well, by and large, HBO is the surgeon's friend, and therefore fits with various conditions that would fall in the disciplines of general, plastic, orthopedic, urological or gynecological surgery, vascular surgery, and maxillofacial surgery. The decision whether or not to provide HBO is a risk-benefit analysis, which considers alternative therapies, the cost, the morbidity of the disease, and the mortality, whereas the benefit lies in the absence of alternatives, the cost of failure, the morbidity of HBO, which is typically very low, and the quality of life that may be gained if the limb or tissue is preserved. HBO therapy is not for everyone, and therefore we are not overzealous or indiscriminate in its use. Its true value lies within a limited range of very important indications. As long as those are the areas where it is applied, the outcomes are almost invariably good. Just a reminder that when patients are referred for HBO, they need to be registered at reception. This is true for both internal and external referrals of hyperbaric patients to our center at the moment, as we are unable to register them within our facility at present. Hyperbaric oxygen therapy is a safe treatment modality. Every precaution is taken to avoid fire hazards, and the reason for mentioning it here is that surgeons that dress their patients' wounds should kindly avoid petroleum-based products or those that are likely to be flammable. In closing, hyperbaric oxygen therapy is a tool. It provides more oxygen at the moments of greatest need. It is an old, reliable vehicle that has been around since the 1950s, propelled by an increasing body of scientific evidence. This concludes a brief overview of the application of HBO in surgery in particular, as well as diving and emergency medicine. There are many good references on the topic, and if there's interest, we'll be happy to provide them to this group. If you're watching this online, please contact us through the various means we're providing you here. Our contact numbers are listed on this slide, and you're welcome to provide your comments in the sections below or email us so that we may provide you with information about the modality and also assist with the referral of patients. Thank you for your time in watching this presentation on hyperbaric oxygen therapy.